Okay, let's unpack this. You know that feeling when you're trying to navigate a really complex system? Maybe it's finances or dealing with insurance or getting health care.
Mm-hmm.
Well, our sources today reveal this incredibly complex web of healthcare policies. And it's not just, abstract rules. It's about how these things directly affect whether you can get the care you need when you need it.
Yeah, and how it impacts the doctors and nurses providing that care, too.
Exactly. So this deep dive is based on a critical review. It's titled Health Policy Challenges and Reforms: Critical Updates for Orthopedic Surgeons.
And what's really fascinating, I think, is how all these different policies, like how doctors get paid, rules about where they can practice, they all kind of mesh together.
Right.
And they create these, well, pretty significant challenges. So our mission today is really to unpack these key hurdles, these policy developments that are shaping things for patients and providers.
So you get a clear picture of where things stand and, what's really at stake.
For the whole healthcare system, and importantly for you.
Okay, so where should we start? Maybe with something that hits providers right in the wallet: Medicare reimbursement.
Yeah, that's a huge one. The core issue here is this really significant drop in what Medicare pays physicians.
How significant are we become?
We're talking about an alarming 29% decrease since 2001. 29%.
Wow. Since 2001.
Yeah. And get this, unlike pretty much everywhere else, physician payments aren't adjusted for inflation. There's no link to the Medicare Economic Index, which basically tracks how much it costs doctors just to keep their practices running.
That's kind of hard to believe, actually.
Yeah.
So a 29% cut over 2 decades without even keeping pace with rising costs.
Precisely. And, connecting this to the bigger picture, falling reimbursement isn't just about a doctor's income.
Right. It must affect the practice itself.
Absolutely. It threatens the sustainability of practices, especially in fields like orthopedics that need specialized equipment and staff. And that ultimately can limit your access to essential care.
Do we have specific examples, like for certain procedures?
We do. For instance, looking at orthopedics, the inflation-adjusted Medicare payment for shoulder procedures, down about 29.3% between 2000 and 2020.
Okay.
And for elbow procedures, down around 24.5% in that same period. It really does suggest the system isn't valuing that complex care financially.
So that 29% overall decline is just staggering. How are practices even managing? With business costs definitely not going down.
It's a huge pressure. The conversion factor, that's the basic rate Medicare uses to calculate payments, it was $32.74 in January 2024. That was already down from $33.89 in 2023.
Okay, so it dropped.
Right. Now, there was a slight bump later in the year from the Consolidated Appropriations Act up to $33.29.
It's a small fix.
A very small fix, and still lower than the year before. And worse, the proposed rate for 2025, it's even lower, $32.36. That's another 2.8% cut.
And you said practice costs are going up?
Predicted to go up 3.6%. So you combine that cut with the cost increase, you're looking at a net decrease of about 6.4% in what doctors actually have to run their practice on.
That's the 5th year in a row of pay cuts.
5th straight year.
Yeah.
It really makes you wonder how long that's sustainable.
Is there anything on the table to fix this? Any proposed solutions?
There is. There's a bill called the Strengthening Medicare for Patients and Providers Act, H.R. 2474.
Okay. What does it do?
It's pretty straightforward, actually. It aims to finally link those annual payment updates to the Medicare Economic Index. So basically, tie payments to inflation and practice costs.
That sounds logical.
You'd think so, right?
Yeah.
It's got bipartisan support, introduced by 4 doctors who are in Congress, and it has 170 co-sponsors already.
So what's happening with it?
It's been referred to subcommittees, so it's in the legislative process, and it's got strong backing from groups like the American Academy of Orthopaedic Surgeons, the AAOS, and about 120 other medical groups.
Okay, so that's the financial squeeze. But you mentioned earlier it's not just less money, it's also more
hassle.
More hoops to jump through.
Exactly. Which brings us nicely to the next big area. The managed care maze, specifically Medicare Advantage and this thing called prior authorization.
Medicare Advantage. That's huge now, isn't it? Seems like everyone's seeing ads for it.
It really is. It grew out of what used to be Medicare Part C. The idea was the government pays private insurance companies more, and they can offer extra benefits, dental, vision, maybe $0 premiums, caps on out-of-pocket costs.
Then people signed up.
In droves. By this year, 2024, over 54% of everyone eligible for Medicare is in an MA plan. That's about 32.8 million people.
Wow. And the cost.
Huge federal spending, around $462 billion.
So for patients, it sounds like a good deal on the surface, extra benefits, maybe lower premiums. What's the catch?
Well, that's the dual nature we mentioned. For many people, it works okay, but if you have complex health needs, that's where the downsides pop up.
Like what?
Things like coverage restrictions, suddenly finding out something isn't covered, or needing to go out of network, which can be expensive. Limited provider networks are a big one, especially if you live in a rural area.
Right, your doctor might not be in the plan.
Exactly. And just navigating all the different plan options can be incredibly complex.
And for doctors, what are the challenges they face with MA plans?
It often means a lot more administrative work. Those limited networks can make it harder to collaborate with other specialists. There can be payment issues, getting paid less than traditional Medicare sometimes, and the contracts themselves can have restrictions that limit the care options they can offer.
And that brings us to prior authorization, right? The infamous PA.
Yes, prior authorization. The gatekeeper, as you called it.
What's its intended purpose?
Officially, it's meant to ensure care is medically necessary and appropriate and to control costs. That's the stated goal.
But the reality seems different. I saw a stat earlier that was pretty shocking.
Which one? There are a few.
That 24% of doctors reported a serious adverse event for a patient because of PA delays or denials. 24%.
Yeah, that's deeply concerning. And it aligns with other data. A 2023 survey found 94% of doctors reporting care delays due to PA. 94%.
And the time spent on it, you mentioned that earlier.
12 hours. Physicians and their staff spending, on average, 12 hours per week just dealing with PA requests.
12 hours? What are they doing in those 12 hours? Like seeing patients.
Exactly. It's a massive administrative drain. And no surprise, 95% of physicians say it contributes significantly to burnout.
And is the process even based on good medical evidence?
That's another major criticism. In that same survey, 35% of doctors said the PA criteria used by insurance plans are rarely or never evidence-based.
So it feels arbitrary sometimes.
That's the frustration you hear. Especially in orthopedics, PA often delays things like getting an MRI or starting physical therapy, even though most requests eventually get approved anyway, maybe after an appeal.
And the person reviewing the request might not even be an orthopedic specialist.
Often not, no. And these delays aren't just inconvenient, they can genuinely lead to worse outcomes for patients. If you delay treatment for certain orthopedic conditions, recovery can be harder.
It really makes you question that original goal, doesn't it? Is it controlling costs or just creating barriers and burnout?
That's the core question being asked. Are we achieving appropriate care and cost control? Or are we actually increasing system costs through delayed care, complications, and physician burnout? It's a classic example of how a seemingly rational idea can go wrong in practice.
So is anything being done about this? Are there reforms happening?
Yes, thankfully, there's movement on this front. The Centers for Medicare and Medicaid Services, CMS, finalized a rule back in January 2024.
CMS 0057-F.
That's the one. It's aimed at improving how health information is exchanged and trying to streamline the PA process, particularly targeting some of the issues with Medicare Advantage plans.
And was there a bill in Congress related to this?
Yes, the Improving Seniors' Timely Access to Care Act. It actually passed the House unanimously in the last Congress, but didn't make it through the Senate.
What would it do?
It would mandate electronic PA systems get rid of the fax machines, require real-time decisions for services that are routinely approved anyway, and make insurers publish their PA approval and denial rates, and how long decisions take.
So transparency and efficiency. Did it get reintroduced?
It did in the current Congress, and again, it has strong bipartisan support in both the House and Senate, so there's hope there.
Okay. And I think I saw something about a gold card.
Yes, the Gold Card Act, H.R. 4968. Introduced in July 2023. This is a really interesting approach.
How does it work?
The idea is to exempt doctors from PA requirements for Medicare Advantage plans if they have a proven track record of getting their requests approved. Like if 90% or more of their PAs were approved in the last year, they get a gold card and bypass the process for the next year.
So it rewards good behavior, essentially, instead of penalizing everyone.
Exactly. It's modeled after a law that's apparently been successful in Texas. The thinking is, let's focus the oversight on the outliers, the ones whose requests are frequently denied, rather than burdening physicians who consistently follow the guidelines.
That seems much more targeted. Okay, so we've got financial pressures, administrative hurdles. What about other professional challenges, like legal risks?
Right. Let's shift gears to medical liability and another contentious issue. Non-compete clauses.
Medical liability, malpractice lawsuits. That must be a constant stress, especially for surgeons.
It absolutely is. The stats are pretty stark. For orthopedic surgeons, over 30% get sued each year.
30% a year.
Yeah. And a lawsuit, even if it's ultimately dismissed, can have a huge impact professionally and personally.
What are the bigger problems with the liability system itself? Does it actually help injured patients?
Well, the AOS points out several systemic failures. One is that it often fails to compensate genuinely injured patients in a timely way. It can also interfere with the doctor-patient relationship.
How so?
It encourages what's called defensive medicine, doctors ordering extra tests or procedures not because they're truly necessary, but to protect themselves legally in case something goes wrong.
And that costs money, right?
A lot of money? AAOS links defensive medicine to nearly 10% of all U.S. healthcare spending each year. Plus, the fear of lawsuits can actually reduce patient access if it discourages doctors from practicing in certain high-risk specialties or areas.
So how do you fix something like that? Is it federal law?
Mostly no. Tort law, which covers this, is mainly handled at the state level, so federal reforms are difficult. Most efforts involve state-by-state changes, sharing strategies between states, and lobbying by medical groups.
What can individual doctors do, besides just hoping they don't get sued?
Meticulous documentation is key. Poor records are apparently a factor in almost 20% of malpractice cases.
And the cost of insurance must be significant too.
Oh, absolutely. Liability insurance premiums can be very high, and they've been rising. In 2022, some saw increases as high as 36%, though the average was around 8%. It's a major overhead cost for practices.
So doctors are worried about getting sued, and then on top of that, they might have contracts limiting where they can even work. Let's talk about non-compete clauses.
Right, non-competes. These are clauses in employment contracts that basically say, if you leave this job, you can't practice medicine within a certain geographic area or for a competing hospital or practice for a set period of time.
Why do employers use them? What's the argument for them?
The main arguments are to protect the employer's investment. Maybe they spent money training the physician or building up the practice. They also want to prevent doctors from leaving and immediately taking a chunk of patients or referral sources with them. Protect the business, essentially.
Okay, I can see the business logic, but what's the impact on doctors and patients?
Critics argue the impact is pretty negative. They say non-competes limit patient access to care, especially in underserved areas, because doctors can't easily move to where they're needed.
Yeah, if your doctor leaves, you might have to travel much farther, or they might be forced to leave the state entirely.
Exactly. It disrupts continuity of care. It reduces patient choice. And for physicians, it undermines their autonomy, limits their career options, and can force them and their families to relocate just to keep working.
That seems like a pretty big restriction. Has there been any pushback on these?
Huge pushback. It led to the Federal Trade Commission, the FTC, stepping in pretty dramatically. On April 23, 2024, the FTC issued a final rule that would ban most non-compete agreements nationwide for almost all workers, including physicians.
A nationwide ban. Wow. What did the FTC say the benefits would be?
They estimated some massive potential benefits, things like reducing healthcare costs by anywhere from $74 billion to $194 billion over 10 years.
Billion. With a B?
Yep. Increasing worker wages significantly, maybe up to $488 billion total, adding over $500 a year to the average worker's pocket. Spurring new business formation, like 8,500 new businesses a year, and even boosting innovation, leading to thousands of new patents annually.
Those are some huge claims. It sounds like a game changer if it happens, but you said if. Is it being challenged?
Oh, yes, big time. There's significant legal uncertainty. Just this past August 20th, 2024, a federal court in Texas, the Northern District of Texas, issued an order basically stopping the FTC rule from going into effect.
On what grounds?
The court said the FTC likely exceeded its authority in issuing such a broad rule and called the rule itself arbitrary and capricious.
So where does that leave things? Is the ban dead?
Not necessarily. The FTC has said it plans to appeal the court's decision. But for now, the nationwide ban is on hold. The FTC can still go after non-competes they deem unfair on a case-by-case basis, but the sweeping ban isn't currently enforceable.
So that debate is far from over. It really highlights that tension between the business side of medicine and the actual practice of care.
It absolutely does. It raises that fundamental question. How do you balance protecting business investments with ensuring patients get care and doctors have reasonable freedom? The legal battle over the FTC rule really underscores that deep tension.
You mentioned smaller practices earlier. Is there an argument that some non-competes might be reasonable maybe for a very short time or limited scope, particularly if a practice really did invest heavily in unique training?
That's definitely part of the counter-argument you hear. While the FTC to a broad approach, some argue that non-competes, if narrowly tailored, could serve a legitimate purpose, especially for smaller independent practices worried about stability if newly trained doctors immediately leave for a competitor across the street.
Right.
The concern is whether a complete ban throws the baby out with the bathwater, potentially harming the viability of practices that made significant investments in their physicians. So it's that balance, again, protecting the physician's mobility versus the practice's investment.
Okay, let's move to our final section. This is about control and how care is actually delivered. First up, physician-owned hospitals, or POHs.
Right, POHs. There was a time when these were seen quite positively fostering innovation, maybe providing higher quality care at a lower cost. They were often smaller, specialized facilities.
But something changed.
Yes, the Affordable Care Act in 2010 effectively put a stop to them, at least for Medicare and Medicaid. The ACA banned new physician-owned hospitals from participating in Medicare and Medicaid, and it severely restricted the expansion of existing ones.
Why? What were the concerns?
The main concerns revolved around self-referral, the idea that physician owners might refer patients to their own hospital, even if it wasn't the best or most cost-effective option. Conflicts of interest, essentially. And there were worries they might cherry-pick healthier, better-insured patients, leaving traditional community hospitals with sicker, less profitable ones, potentially destabilizing the whole system.
So it's a pretty divisive topic. Are people trying to bring POHs back?
Yes, there's a push to lift that ban. Proponents argue that POHs actually increase competition, which can drive down costs and improve quality. They point to data, some from the AMA, suggesting POHs often rank highly on quality metrics, and they argue POHs could save Medicare billions.
Is there legislation for this?
There is. It's called the Patient Access to Higher Quality Healthcare Act of 2023. It aims to repeal the ACA ban.
But the opposition must still be strong. From traditional hospitals, maybe?
Very strong. Groups like the American Hospital Association argue forcefully against lifting the ban. They stick to those original concerns, that POHs undermine community hospitals, often don't offer essential services like emergency rooms, focus too much on profitable, commercially insured patients, and create those referral conflicts.
Is there any data supporting their side on the cost issue? You said proponents claim savings.
Well, the Congressional Budget Office, the CBO, estimated that the current restrictions on POHs actually save the government about $500 million. So that directly contradicts the idea that allowing more POHs would lead to savings. It really depends on which analysis you look at.
So completely different views on whether they're good or bad for the system overall.
Exactly. It's about fundamentally different visions for how healthcare should be structured and financed.
Okay, one last crucial topic. Moving away from opioids for pain management.
Yes, a really vital area. This is, of course, a direct response to the devastating opioid epidemic that really took hold in the 1990s and caused such widespread harm.
There was a legislation passed recently to address this, right?
That's right. The Non-Opioids Prevent Addiction in the Nation Act, the No Pain Act. It was signed into law in December 2022.
And what's the goal of the No Pain Act?
The main goal is to encourage the use of non-opioid pain relief methods by changing how Medicare and Medicaid pay for them. Basically, making it financially viable or even advantageous for doctors and hospitals to choose non-opioid alternatives when appropriate.
How does it do that specifically? Changing payments?
Yeah, it works through a few mechanisms, providing separate payments for certain non-opioid treatments, adjusting bundled payments for surgeries to better cover the costs of these alternatives, and expanding coverage in outpatient settings like ambulatory surgery centers.
So, removing financial barriers to using non-opioids.
Yeah.
What are the benefits for patients, especially, say, orthopedic patients after surgery?
The benefits can be huge. First, avoiding the side effects of opioids, nausea, sedation, constipation, which can really slow down recovery. Using non-opioids often allows patients to get up and start moving sooner, which is critical after many orthopedic procedures.
Faster recovery, then.
Faster recovery, reduced risk of developing opioid dependency or addiction, and generally improved patient outcomes and satisfaction. It's about safer, more effective pain management.
Is this actually being implemented now? Are the payment changes happening?
Yes, it's rolling out. Just this past July, CMS released its proposed rule for payments in 2025 for outpatient departments and surgery centers, and it included detailed guidelines for implementing these No Pain Act policies, including those expanded reimbursements for non-opioid pain treatments.
So, policy's really trying to align the financial incentives with this major public health goal.
Exactly. It's a prime example of policy directly influencing clinical practice to address a crisis. We're seeing a critical shift in how we approach pain management, supported by these new payment structures.
Okay, wow. We have kind of a lot of ground today.
We really have.
From that steep decline in Medicare payments, the whole maze of Medicare Advantage and the prior authorization roadblocks, to the pressures of medical liability, the fight over non-compete clauses, the debate about who should own hospitals.
And finally, the important progress being made in non-opioid pain management.
It really underscores that these aren't just, technical policy details. They have a profound impact on whether you can get care, the quality of that care, and whether the whole system can even keep running.
Absolutely. These are all interconnected pieces. They affect the doctors, the hospitals, and ultimately, they shape your experience as a patient navigating the healthcare system. Understanding these reforms, these challenges, it's pretty crucial, I think.
It really is.
Yeah.
For too long, healthcare policy can feel like this opaque thing happening far away. But as we've really dug into today, these policies, they're not theoretical at all. They're like the scaffolding for the entire system.
Yeah, determining everything from whether a surgeon can afford to keep practicing to whether a patient gets access to the care they need.
So thinking about everything we've discussed, all these moving parts, all these debates, here's a final thought for you, our listener, to consider. What aspect of healthcare policy do you think holds the most immediate potential for positive change? And, perhaps just as importantly, why might making that change be so incredibly challenging?